Thank you, Dr. Aparna, Dr. Ramparisa sir, and those who attend the Hindi session.
Thank you very much, sir.
Good evening, good afternoon, and good morning. This is the 2148th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. RINKAL Adhyaru. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself so that those who miss the session can watch it again. You can subscribe the same without paying any money. You can share it with anyone who loves homeopathy. The purpose of this forum is to take homeopathy to every home around the world. We have so far uploaded nearly 3,900 videos at YouTube, and those who missed the session can search IFPH at homeopathy at YouTube. So let me come to today's guest. Today our guest is Dr. RINKAL Adhyav, and Doctor is doing his MD at the Department of Practice of Medicine, Rajkot Homeopathic Medical College, Pearl University, Gujarat. And this is very important because we love doctors of young dynamic personalities who come over here and present their contents, their knowledge, because they are having very good touch with the social media also. So these people can do wonders for homeopathy in the future. So we are highlighting them as the best doctors for the coming generation. We want to make you the best among doctors. So, Doctor will be talking about a very important subject, that is clinical management of contact dermatitis. We all know that homeopathy can do wonders in all all whatever be the case that come forward. But in skin condition, dermatological conditions, we are number one. So we proudly welcome the guest of the day, Dr. Ringal Adhyav.
Yes, sir. Thank you, sir. Am I audible, sir?
Yes, everything fine. You can go ahead.
Okay. Shall I start, sir?
Yes, yes.
Yes. Okay. Good evening, everyone. Respected moderators, distinguished faculty members, fellow doctors, students, researchers, and all the participants from all over the world. A very warm welcome to all of you. First of all, I would like to express my sincere gratitude to the International Forum for Promoting Homeopathy, IFPH, for giving me this wonderful opportunity to share my thoughts on a clinically important and frequently encountered dermatological conditions. I, Dr. RINKAL ADHVARYU, PG Part 2 from Department of Practice of Medicine, Rajkot Homeopathic Medical College, Parul University, Gujarat. Today, I will be speaking on clinical management of contact dermatitis from diagnosis to an individualized homeopathic approach. So, let me begin with a simple meaning of contact dermatitis. Contact dermatitis
Yes,
is
doctor. Do you want to share the screen?
yes, sir.
You can do it now.
Okay, sir.
Unfortunately, the number of participants from student side is very less. And this is a big problem because we are encouraging the students to make their presentation. So always share these programs to the students group and ask the students to come over here because the future of homeopathy is in your hands.
Okay, sir. So, first of all, what is the simple meaning of contact dermatitis? Is that dermatitis is not merely a skin eruption, it is the skin response to an environmental triggers or environmental antigens or by the occupational exposures. And from a homeopathic perspective, it is the individual susceptibility. In today's session, we will bridge the conventional clinical diagnosis with individualized homeopathic case management, enabling us to approach these cases on more scientifically and confidently. With this introduction, let us begin by understanding what exactly contact dermatitis is and why the accurate diagnosis and is the foundation of successful management. So, the session is start with today's agenda. So, here is the agenda of today's session. In first of all, we see the clinical understanding of contact dermatitis, types, etiology, and pathophysiology. The third one is the diagnostic clinical approach and differential diagnosis. Fourth is the investigations and conventional management. Fifth is the individualized homeopathic approach, including case analysis and remedy selection. And the last and the foremost, most important, is the clinical tips and practical take home messages. Now, the introduction. What is contact dermatitis? Contact dermatitis represents a significant clinical challenge as a prevent inflammatory eczematous skin disorder that triggered by environmental exposure. It is broadly defined as an adverse cutaneous reaction characterized by inflammation, swelling, and pruritus resulting from direct contact with a specific substance, organism, or a chemical. The condition arises through two primary pathogenetic pathways. The first one is the direct toxic effects of the chemicals or beta ions on the skin barrier is called the irritants, and this type of the dermatitis is called as irritant contact dermatitis. And the second one is the because of adaptive immune response by type 4 hypersensitivity reaction. So this type is called the allergic contact dermatitis. Now the epidemiology. How many cases are seen of contact dermatitis? So the first one is the prevalence. Contact dermatitis affects the 15 to 20 percentage of the general population and is one of the most common inflammatory skin disorders. Types. As I said, there is a two types of contact dermatitis. The first one is the irritant contact dermatitis, which is the most common, seen in 80% of the cases. And the second one is the allergic contact dermatitis. It is slightly rare and seen in 20% of the cases. It results from the delayed hypersensitivity reaction. What are the risk factors of contact dermatitis? That approximately 20% of the people worldwide are sensitized to at least one contact allergen. The condition can occur at any age but is twice common in women due to the greater exposure to cosmetics, jewelries, fragrances, infant the elderly and individuals with atopic dermatitis are at the higher risk. So, basically, there are two types of contact dermatitis. The first one is the irritant contact dermatitis and the allergic contact dermatitis. So, what is the irritant contact dermatitis? In irritant contact dermatitis, this is a non specific inflammatory response resulting from direct chemical exposure to damage to the skin. It leads to release of the inflammatory mediators predominantly from epidermal cells without requiring a T cell mediated response. Irritant contact dermatitis is the more common variant, often associated with cumulative exposure to substances such as detergents, soaps, and acidic cleansers. Usually, it is limited to the areas which are in context. The next one, second, is allergic contact dermatitis. The allergic contact form of the dermatitis is classified as a delayed type 4 hypersensitivity reaction. It occurs when the immune response becomes sensitized to exogenous antigens such as nickel, fragrances, preservatives, leading to the T cell mediated immune inflammatory response upon subsequent exposures. So, here in this case, the nickel is the more common and the most common cause of the allergic contact dermatitis. Now, what is the etiopathogenesis of contact dermatitis? So, here in this diagram explains how both irritant contact dermatitis and allergic contact dermatitis eventually lead to inflammation, but through the different mechanisms. In the center, the skin comes into the contact with a chemical such as cosmetics, soap, detergents, metal, or occupational chemicals. These chemical causes damage or stress to the skin cells, which is the first step in both the type of contact dermatitis. On the my left side is the irritant contact dermatitis. Here, the chemical has a direct toxic effect over the skin. It activates the innate or non-specific immune system, damage keratinocytes, and release cytokines and chemokines, producing inflammation. These produces does not require prior sensitization. So, anyone exposed to a strong enough irritant can develop this type of irritant contact dermatitis. On the right side of my is allergic contact dermatitis. In this condition, the chemical acts as an allergen or a heptan. After penetrating the skin, it binds to the protein. After this protein penetrating, presented T lymphocyte, there is a presence of T lymphocyte is present. This activates the adaptive or specific immune response, particularly cytotoxic T cells. Upon re-exposure to the same allergen, these memory T cells produce a type 4 delayed hypersensitivity reaction leading to the inflammation. Therefore, although the pathways are different, both the conditions result in the release of inflammatory mediators and ultimately produces a clinical features of erythema, edema, papules, vesicles, itching, and sometimes scaling and lichenification are present. Generally, lichenification is shown in chronic contact dermatitis. Now, what are the causes? The main cause is result from the direct damage to the skin barrier by irritants. And the common irritants we can see is the water and other fluids, friction, acids and alkaloids, solvents and detergents. Now, the onset is strong irritants cause rapid skin damage within the hours or in individual susceptibility, while repeated exposure leads to chronic dermatitis. What are the common sites? Most frequently affects the hands due to the repeated contacts, which is more commonly seen in the women's. Risk group. Individual with a history of atopic eczema are the more common and susceptible. Now, what are the clinical features of contact dermatitis? So here is the diagrams in which there is a distribution clues for contact dermatitis, in which there is a most common is in the hands, which are caused by detergents, cement and rubber gloves, etc. Now, if dermatitis is on the face and eyelids, they is caused by cosmetics, fragrances, hair dyes, etc. Dermatitis on the neck and ears caused by jewelry. Nickel is the most common cause, as I said. Dermatitis on the wrist is caused by wrist straps. Fit, in fit, there is a shoes rubber, leather, etc. In genital area, there is a most common cause is the condoms and topical medications. Now, what are the most common symptoms of contact dermatitis? The most common symptoms which is seen in both the types of contact dermatitis is burning or red rashes is called erythema, dry cracked skin, itchiness, pain, blisters, swelling or oozing or sore and tender skin. Now, two types of the contact dermatitis is present according to their onset. One is the acute contact dermatitis and another is the chronic contact dermatitis. Contact dermatitis usually develops at the site of contact with an irritant or allergen. The clinical presentation depends on the whether the condition is acute or a chronic. So, start with acute contact dermatitis. In acute contact dermatitis, there is a intense itching is present, more prominent in allergic contact dermatitis. Burning or stinging sensation is present, common in irritant contact dermatitis. Erythema may present, redness, edema, swelling, papules and vesicles, small fluid filled blisters are present. Bulla in very severe cases, oozing and weeping lesions. Crusting after rupture of vesicles. Lesions are usually well demarcated and conform to the area of the contact. Now, in chronic contact dermatitis, there is a slow onset with long duration, weeks to months or a longer duration. There is a persistent dryness, is called xerosis, scaling and flickering of the skin. Lichenification may present. What is the lichenification? Thickened skin with exaggerated skin markings is called the lichenification of the skin, as we can see in the picture. Hyperkeratosis may be present. Fissures, painful cracks, especially over the hands and feet, are present. Excoriations due to repeated scratching. Hyperpigmentation or hypopigmentation after the healing. Chronic itching leading to sleep disturbance and impaired quality of life. Systemic symptoms in dermatitis may usually absent, but in severe or widespread allergic contact dermatitis may occasionally be associated with malaise or extensive eczema. What are the key feature findings of this acute and chronic dermatitis? These are the well-defined lesions corresponding to the area of exposure, severe pruritus, severe pruritus that suggests the allergic contact dermatitis. Burning and pain are more suggestive of irritant contact dermatitis. In chronic cases, we show the lichenification is present, fissuring and scaling due to the repeated exposure and scratching is present. Now, what are the allergen and what is the source of that allergen are given in this table. Chromate. Chromate the source of the chromate is from cement, tanned leather, primer, paint and anti-corrosive substance. Cobalt. Cobalt is the source of the cobalt is pigment, paint, ink, metal alloys, etc. Colophony. Colophony is a one type of resin which is present in the glue, plasticizer, adhesive, tape, varnish and polish. The another type of the resin is epoxy. Epoxy which is seen in adhesive, plastics and moldings. Fragrance. We generally know that fragrances are more common in the cosmetics, creams, soaps, detergents, etc. Nickel. Nickel is present in the jewelry, zip, scissors or any other instruments. Paraphenyl diamine. It is the for uh, dye for coloring the hair. Like the most common example is the black henna, shows color developer. Plants. poison oak, garlic plants, etc. Preservatives. Preservatives are in cosmetics, creams, oils, etc. And the rubber chemicals are rubber is most commonly in tires, boots, shoes, belts, condoms, gloves, etc. Now, what are the basic investigations for contact dermatitis? The diagnosis of contact dermatitis is mainly a clinical, but the following investigation help to confirm the diagnosis and exclude the other condition. These are the basic investigation of contact dermatitis. The first and foremost and the gold standard test is the patch test. Patch test identifies the allergens causing allergic contact dermatitis. It read at generally 48 and 72 to 96 hours. It is best seen at 96 hours. The second one is the skin prick test. Usually, it detects the immediate type 1 hypersensitivity reaction. It generally not used for the contact dermatitis, but it can use for differentiate out the chronic urticaria. Third one is the complete blood count. Complete blood count may show the eosinophilia in allergic conditions, help to detect the secondary infection. Fourth one is the serum IgE may be elevated in atopic dermatitis, usually normal in contact dermatitis. Swab or a culture on sensitivity report crusted or infectious lesion to detect the bacteria and guide the antibiotic therapy. KOH or fungal examination helps to rule out the fungal infection like tinea, which can mimic symptoms of dermatitis. Skin biopsy. Skin biopsy is rarely required, used in atypical or persistent cases, shows the spongogenesis and inflammatory infiltrate. Now, what is the management of contact dermatitis? The first and foremost is the by the convention treatment of medicine, identify and avoid the cause is the most important. So, first of all, identify the irritant and allergen by a history or a patch test. As I said, the patch test is best seen at 96 hours. Avoid the further exposure, used protective gloves, barrier creams, and protective clothing. Educate the patient regarding trigger avoidance. Now, the second is the basic care, which is the skin care. Apply emollients, moisturizers frequently to restore the skin barrier. Use mild fragrance free cleansers and avoid excessive washing and harsh soaps. Now, third one is the tropical treatment, in which there is a first line therapy for the convention treatment of medicine. In the mild contact dermatitis, we use the hydrocortisone 1%, but in moderate to severe cases, we use the betamethasone, mometasone, clobetasol, etc. What are the systemic treatment? In systemic treatment, we use the oral histamines like cetirizine, levocetirizine, hydroxyzanide, etc. to relieve the itching. In oral corticosteroid, we use the prednisolone for severe or widespread allergic contact dermatitis. Antibiotics only if secondary bacterial infection is present. Wet dressings, normal saline or by Burow's solution, compresses for acute oozing and vesicular lesions, helps to reduce inflammation and crusting. And the last management is the first and foremost first and foremost in a list, that is the prevention is better than cure. So we can educate the patient, so in which there is a we can educate the patient, we can educate the family members also, in which we can read the product and labels carefully, avoid non allergens and irritants, use gloves appropriately like cotton gloves under under the rubber gloves if needed. And there is a regular use of the moisturizer to prevent the reoccurrence. Now, case study of the contact dermatitis. So, the summary of the case is the this clinical case study explores the homeopathic management of chronic dermatitis in a 42-year-old female patient. The patient presented with painful cracks, bleeding, and intense voluptuous itching on the fingers of both hands, which had persisted over several years and recently exacerbated. Initial evaluation revealed significant aggravating factors, including the contact with detergent and sour substances, alongside a complex psychological landscape characterized by domestic tension and suppressed emotions regarding her living situation. Following a detailed homeopathic interrogation and reperforations, Calcaria carbonica 200 was selected based on the totality of the symptoms. The treatment followed the principle of individualization, addressing both the local skin pathology and the underlying miasmatic or psychological stressors. Within a 1 week of the initial prescription, the patient reported 30 to 40% reduction in the skin lesions and itching. Subsequent follow-ups over the following month showed complete resolution of the cracks and bleeding, with a marked improvement in the patient's overall mental well-being and confidence. This case underscores the efficacy of classical homeopathic prescribing in treatment of inflammatory skin conditions and by addressing the psychosomatic axis at the totality of the individual. Now, here we can start with the case details. So, a patient is 42 years old, female patient. The religion is Hindu, Indian nationality, living with her husband and her son. Her husband is 45 years old and the son is 17 years old, which is in who is in 12th standard. The occupation by occupation she is a housewife. So the presenting complaint is there is a itching since 5 to 6 years. She took allopathic medication treatment, but again itching come back within 8 to 10 days. There is a cracks, too much itching with a bleeding, but the most common crack is on the right side than the left side. The affected modalities are aggravation by after waking up in the morning, aggravation by 7 p.m. The strong elements is the elements from after detergents or sour food, and there is a amelioration by cold wash and uncovering. The concomitant or associated symptom with this presenting complaint is the feverish feeling during the tension is present. So the condition began 5 to 6 years ago, triggered by a chronic exposure to detergent or a sour substance. A chronic course of over the 5 years with a major relapse 1 year ago and severe acute flare-up lasting 8 to 10 days prior to her first consultation. The disease progressed from a simple irritation to painful cracks and bleeding on the fingers, right or left. So, there is a past history is hysterectomy before 4 years and the cause is the uterine fibroid. No any other uh, major illness is seen in the past history. Personal history. The appetite is normal, around 3 to 4 chapatis per meal. There is a desire for sweet, plus the desire for sweet. The thirst is comparatively less, 6 to 7 glass per day. The stool and urine is normal, thermal. She wants cover also in the summer. So I take the chilly patient. The perspiration is offensive. The generally sleep and dreams is normal. There is a sound sleep and dream is nothing specific. Mental symptoms. From the her life space, I took these mental symptoms, these 9 to 10 mental symptoms of the patient. In this, there is a anxiety with irritability, anxiety about future, elements from unfulfillment of desire, sensitive to criticism, suppression of emotions, libertinism, nagging is present, anger from contradiction or from anxiety, fear of thieves or robbers, fear from sudden noise, and desire for company. What are the general examinations? The general appearance of the patient is vitis. The general built and nutrition is the average. The height is absolutely normal. The weight is absolutely normal. The height is 155 centimeter and the weight is 68 kilogram and the BMI is 28.3. There is any absence of any generalized symptoms like anemia, jaundice, cyanosis, edema, all were absent. In skin, there is a pigmentation, hair distribution, warts, etc., cracks and itching of the hands, especially the fingers. Nails are pinks. Gait is normal. No, there is significant lymphadenopathy is present. The vitals are normal. Blood pressure is 124 by 78 mmHg. Pulse is 70 per minute. Temperature is absolutely normal, 98 Fahrenheit. And the respiration rate is 16 per minute. Systemic examination is also a normal bilateral air entry present in CVS. There is a S1, S2 is present. Now, what are the local examinations of that patient? So, on the site, on the palms, the lesions are prominently located over the fingers and interdigital webs, means the space between the fingers and the palms. Bilateral involvement, both the hands are involved through. There is a clear asymmetry with one hand, likely the right showing the more advanced skin damage. Contact areas, the severity in the interdigital spaces and on the palmar surface is a characteristic of contented exposure where irritants like detergents tend to pull or stay in prolonged contact with the skin. The skin appears extremely dry with fine white scales and a parchment like texture. These indicate a significant disruption of the epidermal moisture barrier. There is a deep, painful looking liner cracks are visible, particularly in the flexors of the fingers and the thumb. The skin on the dorsal aspect of the fingers shows thickening and a darker brownish purple discoloration may present. Erythema. There is a generalized redness and underlying the dry areas indicating the active inflammation. Now, differential diagnosis in which there is a contact dermatitis and allergic dermatitis, we can clear cut in it is a case of contact dermatitis. So the final diagnosis is the contact dermatitis. Now we can start the life space of that patient. First of all, we can see the domestic and environmental context area and joint family dynamics. The patient spent 12 years living in a joint family environment in Rajkot, including her father-in-law, mother-in-law, and her husband's brother, means her brother-in-law. While she described her father-in-law and mother-in-law as a very nice, with a good nature, this environment was source of a significant suppressed tension. Conflict with husband's brother. A major stressor was the husband's brother, described as loquacious, fault finding, and nagging. He frequently gave instruction and unsocialized advice, which the patient resented, and she felt she already knew her duties. Space and privacy. The size of the living space was primarily a driver for her eventual separation into a nuclear unit. She felt a deep lack of independence and felt scrutinized. Now, on the mental and emotional plane, there is a suppression and avoidance. Her primary coping mechanism is avoidance and silence. When confronted with nagging or a conflict, she chooses to just walk away and doesn't speak. This emotional suppression is a key factor in her pathology. Communication style. While she is generally a quiet type who likes to stay in a peace, she occasionally expresses her frustration by shouting or, in the past, by throwing the things. She feels that if she speaks the truth, her family members do not like it and leading to further withdrawal. Dependency and confidence. Despite her inner irritability, she displays low confidence and high dependency on her husband. She requires company while shopping and seeks his consent for all the major decisions. Sensitivity. She is highly sensitive to criticism and overthinks in each and every matter. Current situation stresses, housing anxiety. Her current primary tension is the search for a permanent home. She feels unsettled in a rented space and is anxious to settle down before her 17-year-old son goes to the college. Perception of responsibility. She feels a heavy burden of domestic work. Her irritability often peaks when work is pending or when there are differences of opinion regarding the household. What are the psychosomatic correlation of this contact dermatitis? So, skin as a reflection. The case notes explicitly state in which there is a anxiety reflected on the skin in the form of contact dermatitis. Her physical lesions, cracks and bleeding are the somatic manifestation of her cracked emotional peace and the friction she feels in her domestic life. Now, the analysis and evaluation of the symptoms. So, from the life space, we took a mental general. Those are the anxiety about future, anxiety with irritability, sensitive to criticism, want of self-confidence, and company desire for. Now, what are the physical generals? The physical generals are craving for sweets, too much, offensive perspiration, thermal is chilly. As I said, patient wants covering even in the summer. What are the physical particulars? So, here the physical particulars are itching, cracks, bleeding on fingers of hand, aggravation by after waking up in the morning and after 7 p.m., elements from detergents and sour food, amelioration by cold wash and uncovering. So, totality of the symptoms are anxiety about future, anxiety with irritability, sensitive to criticism, desire for company, lack of self confidence, desire for sweet, offensive perspiration, the thermal is chilly, itching cracks, bleeding finger of the hand, aggravation by after waking up in the morning and detergents, and amelioration by cold washing. Taking by a Kantian approach, we make a repertorial totality. So, in that, there is a mind, anxiety, future about, mind, anger, irritability with anxiety, mind offended easily, mind, company desire for, mind, confidence, want of self, stomach, desire sweet, perspiration, odor, offensive, generalities, cold in general, aggravation, skin inflammation, skin itching, scratching, amelioration. So, here is the repertorial sheet in which the Calcarea cup covers the uh, 9 symptoms from the each symptoms. So, Selection of dose and potency. Here is the criteria for potency selection, in which there is a patient age is 42. So we choose the medium potency, as we know that the pace is fast. So there is a high potency. Pathology. The pathology is reversible, as we all know that contact dermatitis is a reversible condition. So we choose the medium potency. General vitality. There is a hysterectomy present. No, any other past illnesses is present. So we can choose the medium potency. Lifestyle is modern, but is not that much of modern. So we can use the medium potency. Suppression. There is a one OT in the past is the hysterectomy. So use the medium potency. There is a PQRS is available, and there is a highly characteristic symptoms are available on the mental and physical plan. So there is a level of susceptibility is high. There is a no addiction. So level of susceptibility is high. Sensitivity of nerves and mind, as we all know that there is a highly sensitive person. So there is a level of susceptibility is high. Correspondence, mental general, physical general, and physical particular. We can see all the picture. So there is a high potency. Now, what is the prescription? The prescription is Calcarea carbonica 200 single dose and Seclec 4 by 3 by 70s. Now, what are the auxiliary measures we can give to the patient? So, in this case, we can advise the patient for a protective equipments, wear appropriate gloves, example, cotton or linen or rubber to protect the hands from a wet work, chemicals or allergens. Avoid scratching. Keep nails trimmed to prevent the secondary skin infections caused by scratching. Clothing considerations. Wear long sleeved garments when in the areas with potential plant allergens. Proper hand hygiene maintain. After washing hands, dry them gently and apply moisturizer immediately, preferably while the skin is still slightly damp. Moisturize frequently. Use thick, fragrance free, hypoallergic emollients and creams to repair the skin barrier. Soap alternatives. Replace the regular soap with mild fragrance free and non irritating cleansers. So, in follow-ups, in the first follow-up, patient came with 30 to 40% relief in the skin complaints in 7 days. The itching is reduced and patient reported that feels much better and tension is reduced. Brother reported that the patient is cried for 2 hours at night after the day of case taking. So the treatment was the Seclec, and in the remark there is a improvement. Again, uh, after 15 days there is a no fresh complaint, and there is a also itching and cracks are reduced. So there is a again treatment is the Seclec for 1 month, and after that again and again patient feels better and better. So on the 8th May 2026, there is a no any mental or physical complaint. So we just gave the Seclec for 1 dose, and the patient is recovered. Here is the before and after treatment images of the patient. Now, discussion on the psychosomatic axis. The most striking feature of this case is the direct correlation between the patient's mental state and her cutaneous pathology. In homeopathy, the skin is often viewed as an organ of expression for internal turmoil. The patient's life space was characterized by years of suppressed emotions and the lack of autonomy within a joint family and anxiety. This internal friction found on a physical outlet in the form of contact dermatitis. Her husband's observation that She overthinks on every matter, and her own admission that anxiety reflects on her skin and confirm a psychosomatic diagnosis. Remedy differentiation and selection. While the local symptoms, deep cracks, bleeding, and voluptuous itching and bleeding, we strongly suggest the remedies like a graphitis or a petroleum. The Kantian approach prioritized the patient innermost generals. Calcarea carbonica was selected not just for the skin, but for the tripod of symptoms like the deep seated anxiety about the future, the marked want of self confidence, dependency on her husband in each and every matter, and physical generals like the craving for a sweets. Unlike pulsatilla, which shared her yielding nature, the patient's thermal state and specific cravings pointed decisively towards the calcarea group. Pathophysiological correlation. The diagnosis of irritant contact dermatitis was confirmed by the clear modality of aggravation from detergents. Chronic exposure had led to hyperkerotic pattern with significant lichenification, indicating that the skin barrier was chronically compromised. By addressing the patient's susceptibility through a constitutional simillimum, the homeopathic treatment did more than just suppresses the inflammation. It restored the skin's innate ability to repair its protective barrier even while environmental stressors persisted. Now, what are the clinical significance? So, there is a rapid improvement, about 30 to 40% relief within the first week and in the first follow up. The eventual resolution of the years of suffering demonstrate the power of individualization. This case supports the argument that is in chronic inflammatory conditions, treating the men behind the disease is more effective than treating the disease in the men. The disappearance of deep fissures and the restoration of normal skin texture without the use of topical steroids highlight homeopathy's role in achieving a gentle and permanent cure according to the aphorism number 2. Now, what is the conclusion? So, here in the diagram, there is a clinical validation of the biopsychological model in the medicine. So, this case clinically validates the biopsychological social model in medicine, which emphasizes that disease is influenced by biological, psychological, and social factors rather than a single cause. In chronic dermatological conditions such as contact dermatitis, merely removing the contact irritant may provide the temporary relief, but it may not result in the permanent recovery. For a long term healing, the physician should identify and address the underlying causes, including the patient's constitutional susceptibility, which include the miasmatic background also, emotional stress, anxiety, unresolved conflicts, and other psychological factors. These factors can influence the outset, persistence, and recurrence of the skin diseases. A holistic approach that treats the patient as a whole, considering the physical symptoms, mental and emotional state, the individual susceptibility, offers a better chance of the sustained recovery and reduces a likelihood of relapse. This case therefore supports the importance of individualized patient-centered management rather than focusing only on the external irritant. So, the key takeaway in a one line of a biopsychological model is that the treat the patient, not just the dermatitis, addresses the biological, psychological, and constitutional factors for lasting recovery.
Okay.
So,
No. Okay,
yes,
Doctor. So our time is already over. Anyway, congratulations, Dr.
oh,
Rinkel.
thank you, sir.
you can definitely become a big teacher because that kind of power was there in your presentation. Absolutely brilliant
Thank you, sir.
presentation. Uh, I would like to say a few words about your the preparation of slide. But we, as you all know, that we are all homeopaths. But take a special caution while preparing the slides because you have done a thing that was never happened in preparing such slide. That is what I would like to say is that what I was meant to say is that you just mentioned about the allopathic medicine as the treatment protocol. Never say that. Never copy paste things like that. Uh, uh,
Okay, sir.
while ointments also, the externals also, you mentioned something about in that no presentation. It's an homeopathy presentation. So never add anything in your copy pasting these things. Very cautious in all those things because those persons who may watch may think in that oh you can do the homeopathic doctors are doing this thing as their side business, so it is not, it's a bad side. So be very much otherwise it's really an excellent session. As what I told in the beginning, you can become a very good professional and not only simply a doctor but you can become a better teacher. That's what I would like to say about the presentation. Since the time is and there is no more time, I am not going to spend much time for discussion. I'm inviting Dr. Rambaresh sir to say a few words and you can say a word of thanks to the session also, sir.
Thank you,
Thank you,
sir.
Dr. Dhanesh, and congratulations, Dr. Rinkal.
Thank
Very
you, sir.
very nice session. Excellent. Describe the contact dermatitis. Very good. According to totality of symptom, case presentation, very good. Select remedy, calcarea carb according to self self confidence and chilly patient and anxiety. Calcarea carb will do according to selection of remedy, according to mind. Very good, है ना? Mind
Yes,
remedy
yes.
जो है treat the patient जो है और mind remedy, selection remedy cure the disease gently, rapidly and permanently, है ना?
Yes, sir.
behalf
Yes,
of IFPH, behalf of IFPH whole team, very thanks, and dynamic personality Dr. Rinkal and dynamic presentation. Thank you very much. Thank you.
thank you, sir. Thank you, sir.
Thank you, Dr. Rambaresh sir and Dr. RINKAL Adhriga and those who attend the Hindi session. Tomorrow, so in the English session, and tomorrow we will have a session from Dr. Hardi Malani, and she is also from Rajkot Homeopathic Medical College, and we'll be talking about menopause beyond hot flashes, homeopathic approach to women's midlife health. So another big session is waiting for you. Hope all of you will join tomorrow. Dr. Ringal, kindly join with your friends for tomorrow's session.
Sure,
Uh,
sure.
because you might have studied with a lot of friends, but you didn't share or you didn't invite all of them to this presentation because you are
Yes,
making such a presentation in a big forum for the first time. So you should call everyone personally and ask them to come over here. Otherwise, we will not be able to propagate homeopathy among public and among doctors. So kindly I share the posters of tomorrow to all of your friends and invite them to the session. And kindly you can talk during the session also. You can ask some questions during the session tomorrow. Hope you will join.
yes, yes, sir.
हमेशा हाँ presentation, again presentation and daily joint the IFPH, और इसी तरह से हम लोग ज्वाइंट होते रहेंगे.
Okay.
आने वाला पीढ़ी समझे ना होम्योपैथिक
Yes.
घर घर होम्योपैथिक हर घर होम्योपैथिक बन जाएगा. थैंक यू.
Thank
फर्स्ट
you.
ग्रेड
you,
ऑफ
sir.
होम्योपैथिक.
Thank you all. Thank you all. Over to Dr. Sheila to moderate the Malayalam session.
താങ്ക് യു ഇംഗ്ലീഷ് ടീം. എല്ലാവർക്കും നമസ്കാരം. ഇന്ന് IFPHന്റെ ദൈനംദിന വെബിനാർ സീരീസായ 2148 ദിവസമായ ഇന്ന് നമ്മൾക്ക് അതിഥിയായി എത്തുന്നത് ഡോക്ടർ N. ഹരിഹരൻ സാറാണ്. അതിനു മുമ്പ് ഒരു നിമിഷം ഈശ്വര പ്രാർത്ഥന. നന്ദി. നമുക്ക് വളരെ പരിചിതനാണ് ഡോക്ടർ എൻ ഹരിഹരൻ സാർ. സാറ് ഇവിടെ നമ്മുടെ IFPH പ്ലാറ്റ്ഫോമിൽ കുറേ ക്ലാസ്സുകൾ എടുത്തിട്ടുണ്ട്. ഈ അടുത്ത സമയത്തും നമുക്ക് ഡോക്ടറുടെ 45 വർഷത്തെ ചികിത്സാ പരിചയമാണ് നമ്മൾക്ക് ഡോക്ടർ വളരെ ഗുളിക രൂപത്തിൽ ഇങ്ങനെ നമുക്ക് തരുന്നത്. ആസ്മ ആൻഡ് ബ്രോങ്കൈറ്റിസിനെ കുറിച്ച് കഴിഞ്ഞ ആഴ്ചയിൽ ക്ലാസ് ഉണ്ടായിരുന്നു, 1ാം ഭാഗം. ഇന്ന് നമുക്ക് 2ാം ഭാഗമാണ് ഡോക്ടർ എടുക്കാമെന്ന് തീരുമാനിച്ചു.